Hi, everyone. Thank you for attending our webinar today about tax season considerations and continuity of health coverage. In 2024, we're going to give folks another minute to get situated, and then we will get started. Okay, I think it's a good time to get started while folks are still, a few folks might still trickle in. My name is Dori Malazanov. I'm here from NASTAD. I'm joined today by Molly Tasso from the ACE/TA Center. As always, this webinar is going to be recorded. I'll share slides and a recording with everyone within a day or so. And I'm also going to share a feedback survey, which I would greatly appreciate if everyone could complete. Also, as a small disclaimer, I suffer pretty severely from allergies. So if there's like a pause at some point, I'm still here. I probably just paused it to take a drink of water or suffer for a second. With that, let's get started. Here's a brief overview of today's topics. First, we'll have a refresher on premium tax credit reconciliation, along with some tips and tricks from peers. Molly from the ACE/TA Center will talk about easy enrollment programs available in a growing number of states. I'll give some updates on Medicaid unwinding. We'll share some changes happening in the Medicare program, and Molly will share resources from the ACE/TA Center. After that, we'll have time for Q&A at the end. If you have any questions, please use the Q&A feature. You can use chat for comments or other information that you want to share with the group. But questions for the presenters should be submitted using the Q&A feature. Otherwise, we could miss your question. So the Q&A feature looks like 2 talking bubbles, and the chat feature looks like 1 talking bubble. I'm going to drop this reminder into the chat feature. So first, let's talk about premium tax credit reconciliation. More seasoned folks on the call may be familiar with a lot of this already, but hopefully there's something new here for everyone. So let's walk through the life cycle of advanced premium tax credits, or APTCs. These are tax credits to offset the cost of health insurance premiums in the marketplace. Unlike most of the tax credits that you are familiar with already, people don't have to wait until they file their taxes to receive a premium tax credit. Instead, they can receive it in advance, distributed evenly throughout the year as a discount on monthly premiums. This allows a consumer or a third-party payer like ADAP to realize the savings right away. This is what we call advanced premium tax credits, or APTCs. When clients apply for marketplace coverage, they apply for APTCs based on their estimated income. Since they won't know their actual income until the end of the year, enrollment staff help clients make an educated guess based on known factors. Known factors include current income, anticipated changes in pay like promotions or seasonal work, and anticipated household changes like marriage or having a child. But of course, the client's circumstances could change at any time, and the income or household size they originally estimated no longer matches reality. So after they've enrolled in coverage, clients should report any changes so that their APTCs stay up to date. And then when tax season comes around, clients file their taxes and claim any applicable tax credits, including the premium tax credit. If they received APTCs in 2023, that means that some or all of the tax credit has already been paid to them in advance as a discount on monthly premiums. So now the IRS has to settle up the difference between the amount of APTCs the client already received and the amount that they're actually entitled to based on their year-end income that's on their federal tax return. This is called tax credit reconciliation. If there's a difference between the APTCs already received and the premium tax credit the client should actually receive, then the client could either owe money to the IRS or get a refund. I know that can seem like a lot. Hopefully it'll make more sense as we continue to talk through the process. If you feel that a primer on APTCs would be helpful to you or your staff, we're not going to address that today, but I'm going to follow up with everyone over email with a recording and some additional resources, and there will be some great resources there about APTCs. On the coming slides, we're going to talk about how the IRS reconciles premium tax credits, how ADAP can determine the amount of a client's refund or liability, and what to do next depending on whether a client receives a refund or owes money. So here are some tax forms that you need to know about. First is Form 1095A, which is for anyone who had marketplace coverage. I'll return to that one shortly. Forms 1095B and 1095C are for clients who had coverage outside the marketplace, like Medicaid or an employer plan. These come directly from the insurance company, program, or employer that provided the coverage. So if they're missing, this is also where you would go to try to get them. And the IRS uses this information to make sure that the clients didn't get APTCs in a month when they already had some other type of duplicate coverage. Clients don't actually file these 1095 forms, but they use the information that's on them to complete their taxes. Clients could get more than one of these forms if they had more than one type of coverage during the year. And the information from the forms is used to complete Form 8962, the last one listed here, which is what you use for premium tax credit reconciliation. So let's look closer at Form 1095A. Clients who had a marketplace plan get this directly from the marketplace. It has information about household members that had coverage, the months they were covered, how much they paid in premiums, and how much they received in APTCs, if anything at all. If the client received APTCs, or if anyone in their household received APTCs, they'll use this form to calculate any applicable refund or liability. If the client didn't get APTCs during the year, they can still use this form along with the process that we'll talk about to claim the tax credit as a lump sum. Clients should have gotten their 1095A forms by now. Some folks might get it in the mail depending on their marketplace account preferences, but everyone should receive it digitally through their online marketplace account. And if a client hasn't yet received it, or if it contains errors, they should call the marketplace call center as soon as possible. They can still file taxes without it, but that requires some tricky manual calculations. So getting the correct form is ideal if possible. This is the bottom of Form 8962, which is used for tax credit reconciliation. It's filed as an addendum to the tax return. It has step-by-step instructions for how to figure out the actual amount of tax credit the client should have received based on their actual income, and then reconciling it with the amount of APTCs they received during the year. And by reconciling these two amounts, you can determine a client's refund or liability. Again, the information on those 1095 forms from the previous couple of slides are needed to do that calculation. All that calculation is done on the upper part of this form, which is not pictured here. After that, you end up with a number on line 26 or line 29. So a question that I get fairly often is how can ADAP parse out the amount of a client's total tax refund or their total liability? How much of that is related to their premium tax credits and how much of it is attributable to other things in their taxes that ADAP cannot pay for? Form 8962 will tell you exactly that. So if the client gets a refund, there will be some amount greater than zero on line 26. This is the amount of the refund, and line 29 will be blank. There will be nothing written there. Alternatively, if the client owes money to the IRS, then the amount owed will be on line 29, and there will be nothing written on line 26. So if you need to figure out, client has this total tax bill and only some amount of it is attributable to tax credits, and that's the only part that ADAP can pay. How do we figure out how much that is? This is how you would figure it out on Form 8962, either line 26 or line 29. After completing Form 8962, that information goes on either Schedule 2 or Schedule 3 of the federal tax return, depending on whether the client owes money or gets a refund. And that information then goes on Form 1040, which is the federal tax return form. So after the Form 8962 is complete, it's really just a matter of putting the information on the rest of the tax return in the place where it needs to go. the kind of the hard part of doing that math and figuring out how much the client owes or is going to receive back is the most difficult part of the process. Most clients who receive excess APTCs will not need to repay the entire excess amount. Their liability is capped under law. Clients with incomes over 400% FPL might have been eligible for some amount of tax credits in 2023. It's not typically the case, but temporarily for 2024 and 2025 as well, they might be eligible for some amount of tax credits over 400% FPL. If a client over this range receives excess APTCs, they would need to repay the entire excess amount. The repayment caps don't apply to them. But in most cases, clients with incomes this high are not going to receive much in APTCs to begin with, if they receive anything at all. So there usually isn't going to be a lot to repay. That being said, unusual situations can arise where a client is unfortunately stuck with a large tax bill. Clients with incomes below 100% FPL are not technically eligible for tax credits. However, sometimes a person is found eligible when they first applied for coverage, they got APTCs, and then they ended up with an income below 100% FPL when they filed their taxes. Most likely, this will happen to a client if their income is already very close to that lower limit of 100% FPL, if they're just like a little bit above. But clients who experience drastic mid-year changes, like losing a job, could also end up in this situation. So if they applied for APTCs honestly and in good faith, and they were found eligible by the marketplace, they will not be on the hook for repaying the entire amount just because they ultimately ended up outside of the tax credit range. The IRS will just plug their actual income into the tax credit formula, and typically they will end up getting a refund. The formula will give you, a positive number for every income range. And in the case of someone under 100% FPL, probably they will have a refund, or if not always. This is referred to as a safe harbor. It's a protection for lower income clients, so they don't have to repay tax credits that they received in error, but in good faith, and which they simply just cannot afford to pay back. And they would also be subject to this cap of $350 for single filers. They're under 200% FPL. However, again, I would doubt most, if not all people under 100% FPL will end up with a refund, not a liability. This is a review of HRSA HAB PCN 1401. It's HRSA's policy clarification notice on marketplace tax credit reconciliation. I invite everyone to review it at your leisure. I'll just summarize some key points for today. First, the IRS does not issue tax refunds to third-party payers, only to the taxpayer themselves. So any refund from the IRS is going to go back to the client since they're the taxpayer. However, if ADAP paid the premiums, HRSA's policy is that the refund should go back to ADAP. So ADAPs paying marketplace premiums must vigorously pursue those refunds from clients. Programs also may, but are not required, to cover tax liability attributable to premium tax credits. As always, direct reimbursement to clients using federal Ryan White funds is not permitted. So that means that if a jurisdiction is covering premium tax, if a recipient is covering premium tax liabilities, it must have a process for making that payment that doesn't require reimbursing the client. And we'll talk more about that in a moment. It can definitely be done with IRS payments. So now let's put all that together and look at some typical policies and best practices that we've seen among Ryan White recipients and subrecipients providing marketplace premium assistance. The vast majority of jurisdictions providing this assistance have policies and procedures in place for what needs to be done throughout the year and at tax time. These policies vary by jurisdiction, but here's an overview of some typical policies that we see. When the client applies for coverage, programs will typically require them to take the full amount of APTC that they're awarded. Of course, strongly encouraged for APTCs to only be taken after a thorough look at the client's current and anticipated circumstances to ensure that those APTCs are accurate and that their estimated income on their application is as close to anticipated reality as possible. And enrollment is also a good opportunity to educate clients on the need to file taxes and report changes throughout the year that could affect their eligibility. These are things like changes in income or household size, or eligibility for other insurance. There are also just other types of major life changes that might affect the client's eligibility for coverage that not necessarily directly related to cost, but they might be able to switch plans. So really, any kind of major life change is worth sharing. If ADAP is worth the client sharing if ADAP is paying premiums rather, but the changes related to tax credit eligibility are especially important because they impact the amount of money that ADAP is paying out every month and the amount of money that ADAP could potentially have to recoup or pay later. After the initial application and throughout the rest of the year, programs continue to check in with clients about reporting changes, and enrollment staff support clients with navigating any mid-year changes to coverage that do arise. So this can include adjusting tax credits, switching marketplace plans if a client has a life change, or transitioning between other types of coverage like Medicaid, Medicare, or an employer plan. And then at tax time, programs direct clients to tax resources if they need tax advice. Some programs opt to use Ryan White funds to offer tax prep services to clients, which is allowable under HRSA PCN 1602. Programs pursue tax refunds that clients receive, and jurisdictions that opt to cover client tax liabilities have policies in place to pay the IRS. So here are some tips and tricks that jurisdictions have shared with NASDAD, which can help facilitate smooth reconciliation in compliance with HRSA PCN 1401. Excuse me. ADAPs generally require clients to provide completed and filed tax returns, to provide copies of completed and filed tax returns, including Form 8962, so that ADAP can know exactly how much they're paying to the IRS or recouping from the client. Many programs will send clients a couple letters throughout the year, reminding them about filing their taxes on time and submitting documents to ADAP. Programs typically advise clients to file their taxes and get those documents to ADAP as early as possible. This is especially important for clients that owe money and have to pay by April 15th. So if ADAP is making that payment for them, getting the tax documents as early as possible helps ensure that ADAP can make that payment on time, or else the client could have a late filing penalty from the IRS. If the timing doesn't work out for ADAP to make a full payment by April 15th, there are a couple ways for the client to avoid a late fee. One option is that the IRS can deduct the tax credit liability from the client's total tax refund, or the client can make the payment themselves. Now, if the client gets if the client is getting a refund, but they owe money for tax credits, like that refund is the IRS is automatically going to make that deduction and reduce their refund amount accordingly. Alternatively, the client can just directly make the payment themselves. In either of these two scenarios, the client is essentially paying the IRS the amount that they owe. ADAP can't reimburse the client, of course, but ADAP can make a duplicate payment to the IRS. So the IRS has already taken the money either by reducing the client's tax refund or because the client made the payment themselves. ADAP sends a duplicate payment to the IRS. If that duplicate payment creates an overpayment on the client's account, then the client will get a refund from the IRS. If the client still has outstanding tax debt, still owes money, then their remaining debt will be reduced by the amount that ADAP paid. So that's the first option. ADAP makes a duplicate payment, which generates a refund to the client or reduces the client's total tax bill. The second option, if the client can't afford to cover the liability, which most clients will not be able to, they will not be able to afford to wait for ADAP to make that duplicate payment so they can get their money back. The client can set up a payment plan with the IRS and they can start making small payments right away. Once ADAP makes its payment, the payment plan will be adjusted accordingly. If the client already has other taxes that they owe, that payment plan might be a good option for them anyway. But if ADAP makes the payment, the client's plan will be adjusted. Maybe they'll get some money back. Maybe their future, their outstanding debt will be reduced. But that's how they will realize the impact of ADAP covering that liability for them. IRS payment plans are available at no cost or for a small fee, depending on the client's situation and needs. Programs have also reported that they send client's documentation that the payment was made to the IRS, so the client has it for their records, also good practice. And if ADAP is pursuing a refund from a client, but the client can't pay it up front, ADAP can set up a payment plan with the client. Now, we know that ADAPs have varying success with recouping these refunds. We encourage all programs to document efforts made to pursue refunds, even in cases where recoupment is unsuccessful. And NASDAQ is available to support you with developing fair recoupment policies that meet HRSA's requirements while accommodating the realities of clients' financial situations. So please don't hesitate to reach out to us for that. There are a few ways to make payments to the IRS. If paying online with a bank account or a credit card, make sure to use the client's information since the client is the taxpayer and the payment is for their account. Payment can also be made by paper check. IRS Form 1040V explains how to do that. The IRS requires a social security number or a TIN to be written on a paper check. So it's important to make sure that this complies with your agency's HIPAA policy. You do not have to write on the check that this is for premium tax credits. The IRS will just automatically apply the payment to the client's account. It's kind of like when you make a payment towards your credit card, it doesn't knock out individual charges off your bill, it just adjusts your total balance. Form 1040V tells you exactly what should be on the remittance to make written on the remittance to make sure the payment is applied properly, and it also tells you where to send the check. And programs have shared and in fact stressed that individual checks for each client are better than making a bulk payment, because programs' experience has been that IRS is a lot more likely to make a mistake with applying the payments if it's a bulk payment. There's a new tax filing tool available this year. It's being piloted in the 12 states that are listed here. It allows tax filing for free directly with the IRS with free guidance and support along the way. Unfortunately, one major limitation of this tool is that it's currently not suitable for clients who received marketplace tax credits. So it's not especially helpful for tax credit reconciliation. HRSA wanted us to share the information with you, so we're sharing it here. Not helpful for tax credit reconciliation, but clients with other types of coverage and simple tax situations might find this to be a good resource. So it's something that you all can still share with clients as they're getting ready to file their taxes. And with that, I will pass it off to Molly to talk about Easy Enrollment Program.
Great, thanks so much, Dory. So given we're in tax season, we wanted to take this opportunity to highlight a promising program model called Easy Enrollment Programs. Dory, you can go to the next slide. So Easy Enrollment Programs allow uninsured tax filers to apply for Medicaid and marketplace coverage when they file their state tax return. So this marries together, this ties together the annual tax filing process and then the process of health coverage enrollment. So how this works is that the state can offer a marketplace SEP, special enrollment period, to individuals who seek coverage through an easy enrollment program but are not eligible for Medicaid. And so this has the potential really to also extend beyond tax filing and include leveraging unemployment filings and other sort of benefit filings to again identify, locate folks who remain uninsured and connect them to a marketplace. So currently this can only be implemented in states that operate a state-based exchange. And the federal marketplace SEPs are regulated and set by the federal government, but states do have the flexibility to set sort of own standards and own SEPs. And so that's where you see this Easy Enrollment Program SEP coming into play. So we're going to take a look at Maryland on the next slide, which implemented the First in Nation program in 2020, and sort of walk through this process and a little bit about the results that they've seen in the last couple of years. So simply, you can see on the slide there, it's a box that a person can check. So a tax filer is filing their taxes. A question on the state tax form asks if that person wants to share some of their information like household size and income. The tax filer can check that box, and then the Maryland Health Connection on the back end is then checking to see if they may be eligible for marketplace or Medicaid coverage based on the information provided in their tax return. Next slide. So after that sort of eligibility process is happening in the background, a person would then receive a letter. So, for example, the Maryland Health Connect would mail them a letter explaining their eligibility for Marketplace or Medicaid coverage. And then a person has 35 days from the date on that letter to sign up for a health plan. And how they're doing that is through a special enrollment period that is called a tax time SEP. And so that person can go into the Marketplace, they can enroll or create an account on the Marketplace, their state-based exchange. And then the new SEP question asks if they or a household member received a tax time SEP. They can move through this process, I would say, on their own, working through the online portal. They're also certified navigators, for example, from the Maryland Health Connection that should that would be incredibly helpful to folks. It's a free enrollment service. They can find a navigator in their county. So there's enrollment support out there that can help folks move through this process. So Maryland has seen some really promising results. So during the first year of implementation, more than 60,000 people checked the box, if you will. More than 53,000 were found eligible for Marketplace or Medicaid coverage, and over 4,000 people enrolled in coverage. So 15% found eligible for Medicaid, and 11% found eligible for subsidized Marketplace plans. As of September of 2020, 23% of Marketplace enrollees who signed up through the program were Black, compared to fewer than 17% of enrollees who signed up during the recent open enrollment period. So this program really also is an avenue to address disparities that show up in health coverage enrollment, and also health outcomes and health insurance and utilization. So states are in the varying stages of implementation. On the next slide, you'll see a number of states that have enacted legislation to create easy enrollment programs. This does need to be done, as I understand it, through a legislative process. And so a number of states have passed laws that direct the state to develop a program like this. So again, sort of in varying stages of implementation. But we wanted to share this information with you all to let you know that these programs are growing and more states are adopting them. And it's a really great opportunity to again leverage the systems and the work that folks are already doing, right? So filing taxes, to make that connection to health coverage. And so sharing this with your subrecipients and others, I think, is a great way to just grow the knowledge, make sure that folks understand maybe why this information is being asked on their tax filing, their tax returns too, is another helpful tip. And looking forward to seeing how this can continue to be successful for folks. So with that, I'm going to hand it back to Dory to shift us to Medicaid unwinding.
Great, thank you, Molly. Now we're going to talk about some updates about Medicaid unwinding. I'm sure by now folks are very familiar with what I'm referring to. We have plenty of prior webinars from NASDAD talking about Medicaid unwinding. I invite folks to review those as needed, or reach out to me if you need some guidance on where to find them. Just gonna dive in without the background here and provide some updates. As of March 4th, 2024, 17.7 million people have been disenrolled from Medicaid and CHIP during the unwinding process, which started on April 1st, 2023. So this is a mass disenrollment of almost 18 million people in just under a year, which is really unprecedented and staggering. Of those, 71% could still be eligible for Medicaid. They lost Medicaid because they failed to comply with the renewal process, which is what we call a procedural termination. So this could be because, Medicaid didn't know how to reach them. They didn't know what they were supposed to do because the instructions were confusing. They didn't have adequate language access for their notices. They missed a deadline. Some part of the renewal process was not done properly, or a deadline was missed, and they were terminated even if they still qualified for the program. The remaining almost 30% of disenrollments are people who actually went through a full renewal and were found no longer eligible for Medicaid, which will usually happen because someone's income or household composition has changed since the last time that they went through a Medicaid application, which could have been as long ago as 2020 at this point. A lot of folks, 40% have needed to actually return information to Medicaid to complete their renewal. So this is where procedural terminations are most likely to happen. For the other 60%, Medicaid was able to renew coverage based on available data without asking for any documentation from the client. This is referred to as an ex parte renewal. This slide and the next few include data that's from March 4th. This data has since been updated as of about a week ago. So if you follow the link here, you might see some slightly different figures than what I'm showing here, but they're still pretty close and give an accurate impression. So those nearly 18 million disenrollments were not distributed evenly across the country. On the top here, I have the states with the 10 highest disenrollment rates, and on the bottom are the 10 lowest disenrollment rates. So the green part of the line for each state shows the portion of all completed renewals that resulted in disenrollment, and the dark blue is how many people maintained coverage. Of all the people who've already gone through a renewal, there are still about 34 million people who haven't even gone through a renewal yet. But of those that have, here are the states with the highest and lowest rates of disenrolling folks at the end of that process. So in some states, you have more than half of renewals completed to date have resulted in coverage loss. And then on the other end, there are states where more than 80% of people up for renewal so far have kept their coverage. Procedural terminations are also not distributed evenly. In all but 3 states, more than half of disenrollments thus far have been procedural. So that means that no matter where you live, procedural disenrollments are still a high risk. So if someone loses Medicaid because they missed their renewal deadline, it may not be too late. They don't necessarily have to apply for Medicaid all over again. If they submit their renewal form within 90 days after losing coverage, Medicaid must reconsider their eligibility without requiring a whole new application. However, unfortunately, this does not apply to all Medicaid enrollees. States are only required to reconsider eligibility for what's called MAGI groups. This includes pregnant persons and people in the adult expansion group. But other eligibility groups, non-MAGI groups, which include people age 65 plus and people with disabilities, states can require a whole new application. So the reconsideration there is optional. I mean, they have to implement it consistently for everybody, but they can choose to allow or not allow reconsideration for entire groups. There's of clients at this time are going to be transitioning to other types of coverage. So again, in past webinars, we've talked extensively about all of these. I encourage folks to review those or reach out to me if you need any support with understanding some more context for what's here. Just some quick reminders. There is a special enrollment period or SEP in the marketplace for people who lose Medicaid during unwinding. We call it the unwinding SEP. As a reminder, it's available until July 31st, 2024. Anyone who loses Medicaid between March 31st, 2023 and July 31st, 2024 can use the SEP to enroll in a marketplace plan. They just have to check a box on their application, self-attesting they lost Medicaid. There's no documentation needed. There are also 2 other SEPs for clients transitioning to the marketplace during unwinding. The low-income SEP, which allows clients with incomes below 150% of the federal poverty level to enroll or switch plans once per month. It's available across healthcare.gov and in most state-based marketplace states. So clients that means that clients within 150% FPL in all healthcare.gov states and most state-based marketplace states can enroll or switch plans once per month. If you're in a state that doesn't have either the unwinding SEP or the low-income SEP available, there's always the loss of coverage SEP that's always been available, that's always been there. Some state-based marketplaces have extended the deadline for that SEP during unwinding, and healthcare.gov has permanently extended that deadline to 90 days after Medicaid termination. There's also a new Medicare Part B SEP for clients who delayed Medicare because they were enrolled in Medicaid can apply for Medicare when their Medicaid ends. There's no gap in coverage and no late enrollment penalty. And finally, transitioning to employer coverage, clients with an offer of employer coverage through their own job or through a spouse or through a parent can enroll in that coverage after they lose Medicaid or CHIP. This applies for 60 days after they lose Medicaid or CHIP. This applies to all types of employer plans, big and small. We have heard reports of employer plans not following these rules, potentially because they don't want to or because they're not aware of them. So if you have clients who have had challenges or have been told no when they try to seek coverage through their employer plan after losing Medicaid, please reach out to us. We are happy to help. Since a lot of clients are going to transition to private insurance, I just wanted to offer a quick refresher on some important rules to keep in mind. HIV medications must be covered by private plans in a non-discriminatory way. When assessing plans, pay close attention to formulary adequacy. So these are things like exclusions, utilization management, or high tiering. And if you're seeing widespread access issues, please, or even non-widespread, but even more case by case, if you're seeing access issues, please let NASDAQ know. But of course, especially if the problems are affecting, multiple clients, or involving really big employers, really big plans where they could be affecting folks in other jurisdictions as well. Under the federal third-party payment regulation, insurance companies and their downstream entities must accept payments from Ryan White recipients and subrecipients. This includes programs that are based in hospitals. So under this regulation, third-party payment regulation, insurance companies must accept premium payments from Ryan White, and entities that are associated with the insurance company, like a PBM or an in-network pharmacy, must accept co-pays and co-insurance payments from Ryan White. But it's not enough to just accept these payments. NASDAQ's interpretation is that there also can't be unnecessary barriers. So if clients are having to go through all kinds of additional steps and jumping through extra hoops just for ADAP payments to be accepted by their plan, or if payments aren't counting towards a deductible, these are just a couple of examples. Any kind of barrier to ADAP payments being accepted and applied properly could be a violation of the third-party payment rule. So please do let us know if you're experiencing issues like this, and we are happy to help. And finally, the mail order opt-out rule says that insurance companies must allow enrollees to access prescriptions at any in-network pharmacy. Now, the plan can encourage use of mail order by charging higher cost sharing for brick and mortar pharmacies, but ultimately the client must have the option to use a brick and mortar pharmacy, and any amount that they pay must count towards their deductible and out-of-pocket max as appropriate. I've seen situations where plans have charged 100% co-insurance at a brick and mortar pharmacy. So that's like the entire cost of the medication. That's technically allowed because they are allowed to change cost sharing to encourage use of mail order. However, even if 100% co-insurance is paid, every dollar of that must count towards the deductible and out-of-pocket max as appropriate. 100% co-insurance, is not the same as not covered. Now, it is true that many employer plans are going to be exempt from these rules, but programs have had success resolving issues with insurance companies, even when these rules don't precisely apply. There's still advocacy that can be done. There might be other rules implicated that we can call upon. So please do let us know if you're running into any of these issues. Even if a client's plan isn't subject to these rules, or you're not sure, we would love to help you, figure that out and address the issue. Now I will pass this off to Molly from the ACE-TA Center to talk about some Medicare updates. In the meantime, I just want to remind folks, please go ahead and submit any questions using Q&A or share things with your co-attendees in the chat.
Great, thanks, Dory. So just a few Medicare updates before I give a very brief overview of some ACE-TA Center resources we have, and then we'll move into the Q&A. So first, Dory touched on this briefly. Next slide, please. Around a special enrollment period for loss of Medicaid for folks transitioning into Medicare. So just wanted to provide a little bit more information on that. So for folks who are losing or have already lost Medicaid and who didn't enroll into Medicare when they were first eligible, because of course they were still on Medicaid, they can take advantage of an SEP without worrying about any of the late enrollment penalties. So this SEP begins when the individual is notified of the loss of Medicaid coverage, and then it ends 6 months after Medicaid ends. And so they can choose when they want their new Medicare coverage to start. So either the first of the month after enrolling, or they can be retroactive to the month that they lost Medicaid coverage, up to them. But individuals who would otherwise be eligible for this SEP, if they went ahead and enrolled prior to January, so if individuals who otherwise would be eligible for this SEP, if during the public health emergency, so before Medicaid unwinding sort of started, and continuous coverage requirements were in place, if they went ahead and enrolled into Medicare and are receiving late penalties, they can have those late enrollment penalties reimbursed, and then any ongoing penalties removed. And so that's for folks, again, if they lost Medicaid and enrolled in Medicare prior to January 1, 2023, which is when this SEP took place, again, they can have those LEPs removed, and then they can be reimbursed for any for prior LEPs that they had paid. On the next, there we go, thank you. So there's also in terms of financial help for Medicare, there's also the Extra Help Program, and this is also known as the Part D Low Income Subsidies, or Part D LIS. Part D LIS is a federal program that helps individuals pay for some or most of the out-of-pocket costs associated with Medicare Part D prescription drug coverage. The program itself is not prescription drug coverage, just like ADAP is not health insurance, or the Ryan White program is not health insurance. LIS is not prescription drug coverage, and the client must already be enrolled in a Part D plan in order to apply for extra help with these costs. As a reminder, enrolling in Extra Help will eliminate any Medicare Part D penalties that your client may have incurred. And then on the next slide, I wanted to share an exciting update that happened January 1, 2024, so this year. It's the expansion of the federal Extra Help program. So the program used to have, the program used to be broken out into partial or full LIS. Now everyone is expanded into the full benefit LIS. The full subsidy is available to all eligible individuals with incomes below 150% of the federal poverty line. And then individuals eligible for Extra Help are, again, entitled to Part D plans with no premiums or deductibles and modest copays. On the bottom there, just a few don't forget tips around Medicare. So insulin is now available in Part D plans without a deductible for $35 a month. Vaccines recommended by the Advisory Committee on Immunization Practices are available without cost sharing, and Part D cost sharing is capped. And so those are just a few other great sort of relatively new benefits and expansion of benefits that have come about recently from some changes in Congress. So that's a wonderful update to share. And then Dory, do you want to take this next slide around the expanded behavioral health under Medicare?
Great, thanks, Molly. Yeah, a quick update on behavioral health services in Medicare before Molly talks about some HTA resources for a few minutes, and then we'll have Q&A time. So Medicare behavioral health services have been expanded effective this year. Intensive outpatient program, or IOP services, are now covered. Before now, Medicare paid for inpatient care, partial hospitalization, and outpatient care for mental health and substance use disorders. But there are also a lot of people who need more support than what's offered in outpatient day treatment, but inpatient care or partial hospitalization are still, more than what they need, more intensive than what they need. So IOP services kind of meet that in-between need and can now be covered for Medicare clients in a variety of care settings. So it kind of expands services that are needed by a wider range of people and that meet a wider range of health needs. Mental health counselors and family therapists can now enroll as Medicare providers, which is another way of expanding access to behavioral health, because there are hundreds of thousands of licensed mental health professionals that can now offer services to Medicare enrollees and get coverage, get reimbursed for them. And Medicare Advantage plans also have some changes related to behavioral health. These plans will need to ensure that newly covered providers are included in provider networks to ensure meaningful access, and Medicare Advantage plans can no longer require prior authorization for emergency behavioral health. emergency behavioral health specifically, and plans must provide care coordination to advance whole person care for enrollees that need behavioral health services. Back to you, Molly.
Great, thanks, Dory. So just a few things to wrap up. Just wanted to briefly sort of introduce myself and the ACA Center. I know Dory's been referencing me, but my name is Molly Tass. I'm a consultant at JSI and the project director of the ACA Center. So on the next slide, you can see the ACA Center is a HRSA funded cooperative agreement. I would say like a sister COAG to NASDAD's ADAP project. And our job is to engage, enroll, and retain clients in health coverage. Dory, can you go to the next slide? Thank you. Whether that be marketplace or other private health insurance, as well as Medicare and Medicaid, help folks communicate with Ryan White clients about how to stay enrolled and use health coverage, and also improve clarity. So improve the clarity of information shared with clients around healthcare access and health insurance. You can go forward 2 slides, Dory. Thank you. So just a few, given the very important intersection and relationship between tax filing and health coverage, we have a number of resources both for Ryan White recipients, subrecipients, and also clients that help explain this process and help folks sort of walk through the process. So on the next slide, you'll see we have an Understanding PTCs and CSRs, an e-learning and on-demand e-learning module. This resource is a self-paced interactive course that provides information about PTCs and CSRs and details the process of how clients both apply for these types of financial assistance, and then also how folks who receive APTCs, how they file and reconcile their taxes. And I'll be sharing, Dory will send out a follow-up email and I'll share all the links to these resources, so don't worry about navigating to them now. On the next slide is a helpful searchable FAQ, again on PTCs and CSRs. There we go, thanks, Dory. And again, just helps folks understand the distinction between the 2 types of financial resources, PTC, CSRs, and what they mean for a person's tax filing process. On the next slide, you'll see we also have consumer resources. So these are especially helpful, we found, for folks who might not have internet access or maybe uncomfortable using a web-based tool. So this printable resource can be shared with a Ryan White client. It explains in plain language, again, the intersection between health coverage and taxes, and reiterates the importance of filing taxes and how to go about that. And then finally, just wanted to share with you all that there are some external tax filing assistance options available to folks. On the next slide. So the Volunteer Income Tax Assistance Program, the VITA program, is available for folks who make about $64,000 or less, persons with disability, as well as limited English-speaking taxpayers. The tax counseling for the elderly, or TCE program, is available to people aged 60 or older, and they specialize in questions around pensions, retirement, and other issues related to seniors. And then the IRS Free File program, which provides free tax filing software for people with incomes below $79,000. And in some cases, they might also even be able to assist with state taxes, which is great. So on the next slide, you'll see our website. We're on targethiv.org/ACE. Again, I will share with Dory some links to share with you all after the fact. Please check out our website and all the resources. And with that, I will hand it over to Dory to move us through the Q&A. Looks like we've got some great questions.
Yes, great. Thanks, Molly. We do have some questions. I'm going to put up our contact information on this slide here too. Folks can go ahead and take it down, or we will share it around in my follow-up email. So be on the lookout for that. We do have some great questions here. I'm going to, we have a couple here. If I don't answer your question, it doesn't mean I didn't see it. It could mean that it's just kind of a really individualized situation that I want to address with you offline. And of course, I'll share with the group over email anything, you know, of use that anything of interest to the group that could come out of that. But these seem kind of fact specific. So if I don't answer your question, that could be why. So I have a question here about refunds. When clients get refund checks from the IRS, is their APTC refund separate from the rest of their tax refunds? I've had clients receive a check from the IRS and ask if they can sign it over to us and mail it to us. But I'm wondering if this is their entire refund or just the portion that came from the tax credits. So the client is going to get like one. If they have a refund, they're going to get one payment for their entire refund. It's going to include all the different tax credits and liabilities and refunds from all over their taxes, including but not limited to the premium tax credits. So if if the amount that they got back, so let's step back for a second. If they owe a certain amount of money in tax credits, but then they get a refund somewhere else on their taxes, they're where they maybe owed $1,000 in tax credits at first. Now their total bill is only going to come out to, let's say, $800 because there was $200 from somewhere else where they got a refund, right? So everything kind of like a credit card bill, it all just kind of gets put together in one single resulting balance. So that's kind of how the IRS refund is as well. But I walked through the forms earlier to share kind of how ADAP can figure out the amount of tax credit refund that's included in the client's whole refund. So if there's a number on form 8962 line 26, then the client got a refund and that number will tell you the amount of the refund. Now let's say that the refund that they're due is lower than the amount that they actually get in from the IRS, like because of other areas in their taxes. If the total payment, if the total check they get back from the IRS is less than their APTC refund, they could theoretically do what's described here and give this entire payment over to ADAP because it's not more than what they owe ADAP, it's actually less than what they owe ADAP. So theoretically they would have, an outstanding balance that they still owe to ADAP. I don't see any problem with that. I don't think the fact that the IRS hasn't, itemized all of those items in the refund, I don't think that makes a difference here. It's just about the amount. The amount on line 26 is the amount that the client gets back for tax credits. That's the amount that ADAP pursues. If part of that means signing over the tax refund to ADAP, then that also works. Of course, that only would if the client's refund check is more than what they owe to ADAP, then there would have to be some reconciliation that happens there. But I don't see any other issue with the client just kind of handing over their entire refund to ADAP if that makes sense, given what's on line 26 of form 8962. Okay, so it was a little long-winded, but I think I hopefully answered that question. We also had a question about the employer about standards for formulary inclusion. So this person here, I'm not going to read the whole thing because it's kind of long, but to summarize, this person is highlighting some employer plans that have poor, skimpy coverage of HIV medications. Unfortunately, in a lot of situations, there's employer plans have a lot more flexibility with what they're going to cover in terms of prescription drugs compared to marketplace plans. Even if there's no rule that's precisely on point, like I said, we have successfully helped programs do advocacy to a plan anyway. So reach out to us. We're happy to help with those kinds of issues. That this person had a follow-up question though, that if the employer plan doesn't meet minimum essential coverage, can the client drop that plan and switch to the marketplace? So if the plan does not meet minimum essential coverage, I believe there is an SEP for that. We'll double check, but I'm almost certain that there is. However, I should note here though, that that's a pretty high standard, and unfortunately, really poor coverage of HIV medication does not automatically lead to a finding that a plan does not provide minimum essential coverage, or minimum value rather. So if the employer plan truly is not up to the standards, I believe there is an SEP for that. If I end up being wrong about that, I'll clarify that in my follow-up email. But again, a lot of the time, this plan is probably going to meet minimum value and that would not trigger an SEP to switch to the marketplace. That being said, the next time the client has an opportunity to switch to the marketplace, they can definitely do so. They might not be eligible for tax credits, but we've definitely seen programs have clients enroll in full cost marketplace plans because the employer plan available to them just was not providing the coverage that they needed for their HIV needs.
Dory, I just want to, you are correct. There is an SEP if a person loses minimum essential coverage. To your point, though, that threshold is pretty high. So,
Yeah.
Yeah.
So, generally when we've seen, programs come to us with like some really skimpy plan, the ultimate conclusion is that like this unfortunately is minimum value, but let's see if we can find some other way to improve this situation, this coverage, or find something that's better. Yeah, so I think we probably have time for one more. There was a question here about Part D programs that do not cover HIV meds. I assume this means Medicare Part D. If the person who submitted this wants to reach out to me directly to talk more about what they're seeing, I would really like to hear from you. But if I understand this question correctly, Medicare Part D plans are required to cover HIV medication. Someone here asked about Part D plans that don't cover them. Part D plans are required to cover HIV antiretroviral therapies. So if you're seeing plans that are not covering this at all, please do reach out to us. Molly, I think, was there anything that you wanted to add on this question?
No, but just also recognizing that there can be, and I think it's the sort of follow-up question, that there are situations where the copays are so high that it becomes a sort of cost prohibitive situation then for a client.
But this person who submitted this question, I would love to talk to you more about the issues that you're encountering. So please do reach out. I see a couple other questions here. I'm gonna follow up with these folks over email either today or tomorrow. So stay tuned. I have not forgotten about you. I just want to get some more information before I can answer these questions. So that being said, I think we're ready to wrap up. Again, our contact information is here on the screen. I will follow up with recording slides, follow-up resources from the ACTA Center, from NASDAQ, from other places, and we'll provide any additional information based on the questions. And if any other questions come up, please don't hesitate to reach out. And I hope everyone has a great rest of your Tuesday.